Topic: Scalp. Students should be able to describe the layers of scalp, its blood supply, its nerve supply, and surgical importance. Students should also able to describe emissary veins with its role in spread of infection from extracranial route to intracranial venous sinuses. What is scalp? Scalp is a soft tissue which covers the vault or calvaria of the skull. It extends anteriorly up to the eyebrow or supraorbital margin. Posteriorly, it extends up to the external occipital protuberance and that superior nuchal line. This one is highest nuchal line. Laterally, the scalp extends up to the zygomatic arch. Now, layers of scalp that can be easily remembered by the letters of the word scalp. First is the S, that is skin. C, it is the connective tissue layer. A, aponeurotic layer. L, loose areolar tissue layer. P, pericranium. So these are the 5 layers of scalp. From outside inward, skin, connective tissue layer, and that is dense aponeurotic layer, loose areolar tissue layer, and pericranium. Let me draw the layers one by one. The first layer is the skin. Say this is the skin. Second layer is the connective tissue layer. Basically, it resembles to the superficial fascia, but here there are many fibrous septa are present, which extends from the skin to the third layer, that is the aponeurotic layer, a thick aponeurotic layer. So this is the third layer, aponeurotic layer. So the fibrous septae which extends from the skin to the aponeurotic layer basically divides that connective tissue layer into many lobules which contain fat lobules. Below the aponeurotic layer, there are loose areolar tissue layer, that is the fourth layer. And below this, there is pericranium. This pericranium is nothing but it is the periosteum, outer periosteum of the skull bones. So this is number 1, that is the skin. Number 2, this is the connective tissue layer. This is number 3, that is the aponeurotic layer. This is the 4, it is the loose areolar tissue layer. And 5th, this one is the pericranium. So these 5 are the layers of the scalp. Layers of scalp. As these fibrous septa, which are extend from the skin to the third layer, these three layers are fixed together. They can't be separated. That's why these three layers collectively known as the surgical layer of scalp. And these three layers moves over the other layer of the scalp. Below or inside that skull bone, there is also endocranium, that is the endosteal layer of the dura mater. And that endosteal layer, this is the layer of the dura mater, and within that dura mater there are venous sinuses. Say this is one venous sinus. If it is sagittal suture, then this one is the superior, that is the superior sagittal venous sinus, and from that venous sinus small vein extends above. These are the emissary veins, small thin-walled valveless vein. The word emissary is spy. Basically, they extend from that interdural venous sinus to the veins which are present into the second layer, that is the connective tissue layer. They can easily be torn in this layer, that is the fourth layer. And if there is an infection in this layer, that infection can easily be traveled to the intracranial dural venous sinus. That's why that fourth layer is called as the danger layer of the scalp. Now, if we describe the layers further, the first layer, the skin, it is the thicker one, and here, yes, it contains hair. Actually, the maximum number of hair follicles are present in the scalp and also the sebaceous gland, and that's why the scalp is the one of the important area for that sebaceous cyst. Now about the second layer, that is the connective tissue layer. Already discussed that there are many fibrous septa which has divided that second layer into multiple lobule. It contains maximum amount of cutaneous blood supply. That huge amount of blood supply is there, and the vessel walls are basically attached with that fibrous septa. That vessel, the arteries, the veins are present here, and nerves are also present here. So that neurovascular bundle mainly present in this layer of the scalp. And one of the important thing is that as the vessel walls are attached with the fibrous septa, thereby if there is any damage to the vessel wall or vessel, even a small injury to that vessel can give rise to profuse bleeding. Why? Because the vessels are unable to retract after the cut, which usually occurs, as because the vessels are covered by the sympathetic nerve system. Even the larger vessel of the limbs usually retract after the cut injury. But here they are unable to retract. Why? Because they are attached with the fibrous septa. That prevents that. And also, one of the important thing is that if there is even a small infection, a small collection of pus, that can give rise to immense pain. Why? Because the nerves are there. So, the second layer containing the blood vessels, nerves, and it is being divided by that fibrous septa into many lobules which contain fats. So that's all about the second layer. Now about the aponeurotic layer. Basically, this aponeurotic layer not only contains the aponeurotic things, it also contains some muscles. What is that? Let me explain it going into another picture. It is the third layer of the scalp. Suppose we are looking the scalp from the above. Anterior part, posterior, both ear, and suppose this is the aponeurosis which extends like this. So this thing is the aponeurosis. Here lies 4 bellies, 2 frontal bellies and 2 occipital bellies. And the frontal bellies, it is present here. It is longer and wider in comparison to the occipital one. See, the frontal bellies, the medial wall of the frontal bellies are approximating with each other, whereas the occipital bellies, they are coming from the lateral side. So this is one, this is another. Frontal bellies have no bony attachment. Anteriorly, the frontal belly attached with the skin and subcutaneous tissue around the eyebrow. The deeper fiber of the frontal belly, though attached to a few muscles, they are procerus, corrugator supercilii, and orbicularis oculi. Posteriorly, these frontal bellies are attached to the epicranial aponeurosis. Whereas the occipital bellies have a posterior attachment, where at the highest nuchal line, and anteriorly it is attached to the epicranial aponeurosis. The epicranial aponeurosis is also known as Galea aponeurotica. The word Galea means helmet. The epicranial aponeurosis extends posteriorly. Here it is the external occipital protuberance and that highest nuchal line. Anteriorly, it extends up to the eyebrow. Even that epicranial aponeurosis has no bony attachment anteriorly. One of the important thing regarding this third layer is that the pull of these two muscles can move this aponeurotic layer, carrying the upper 2 layer along with it. Thereby, the upper 3 layer can move freely over the lower ones by the alternative contraction of this muscle. A scalp wound never gave unless there is a cut injury transversely in this epicranial aponeurosis. What happens if there is any transverse injury? Due to the pull of these two muscles, this is going apart, thereby creating a gap in the scalp. So that's why if there is a deep wound in the scalp, we have to repair it. Now these two muscles, they are skeletal muscle, so they have the nerve supply. Both the muscles getting their nerve supply from the facial nerve. So facial nerve supplying twice or two branch, one going like this. This is the temporal branch of the facial, and another which is supplying the occipital belly. This is the posterior auricular branch of the facial nerve. So that is the third layer. And one of the important thing is that this third layer is not attached with the bone anteriorly. Now if we look here, first layer, this is the second layer, and this one is the third layer. We can see that occipital belly is attached with the bone here. But anteriorly, see, the frontal belly is not attached with any bone. Thereby, what happens that the fourth layer basically, it is continuous anteriorly with the superficial layer of that upper eyelid. So if there is any collection over here in fourth layer, that can easily be covered the whole area of the scalp, and even it can gravitate through this. And that is why if there is any collection of blood, say by some injury or after operation, that blood can easily gravitate over the upper eyelid and gradually it will encircle the whole eye. That is known as the black eye. Do remember, the commonest reason of that black eye is not injury or that blood coming from the scalp. The commonest is direct blow over the area of the upper eyelid by injury by the fist. But when it is injury in the scalp and blood accumulating in the fourth layer, that can easily travel and gravitate and it will enter here and causing the black eye. So that is the fourth layer. And another importance of the fourth layer is that emissary veins. Those emissary veins, they are very thin walled. So in any injury, small injury, those emissary veins can be damaged, and there may be a collection of blood. As there is no nerve and no compartment, blood can easily travel all along, even without knowing of that thing. And the infection can easily be traveled through that emissary vein to the deeper dural venous sinuses, which is very dangerous. And those emissary veins are usually present in the parietal bone, just surrounding to that sagittal suture, where they communicate with the sagittal sinus, with that superior sagittal sinus to that superficial vein. And another group is present in the mastoid region, where they communicate with the sigmoid venous sinus to the superficial vein of the scalp. And that's why it is known as the danger area of the scalp. And another thing is that, suppose if there is any damage, the whole damage of this thing, when that pericranium and the dural layer is being teared. In that case, if there is any collection of blood intracranially, even that blood can escape through this. Accumulation of blood intracranial is very dangerous because there is, suppose there is brain, so that can compress the brain. That is dangerous because that can cause instant death even by compressing over the brain, which can compress the brain stem here. So if the blood escape, that is good. That here acts as a safety valve because that fourth layer can accumulate a large amount of blood. At least it can prevent that compression. Here it is act as a safety valve because it has a potential space here. That is the fourth layer. Another clinical importance of the fourth layer. First is that black eye, because injury of that blood can easily travel from this and it accumulate here. That is one thing. Second thing is that any small infection, even causing any pain, it can enter into the intracranial venous sinuses. That's why it is known as the danger area of the scalp. Now, if there is any injury which causing accumulation of blood intracranially, even that can be escaped and that can be kept here, where the fourth layer will act as a safety valve. Now, the fifth layer, that is the pericranium. Here it is the pericranium. I've already discussed that it is the periosteum which covers the outer surface of the skull bone. It is usually loosely attached in this part, but it is firmly attached at the sutural membrane, where it is continued as the inner endosteal layer. So that is the fifth layer. Now, so these are the layers, and I have described the third layer over here. Next thing is the arteries. So how many layers was there? 5 layers. Arteries are also 5 on both sides. We can see both the branches of the internal carotid and external carotid are anastomosing over here. The anastomosis is huge on both sides and in between the branches of the internal carotid and external carotid. Now, what are the branches? Suppose it's the midline. The first thing, the first artery is coming, first two, these two are the coming from the orbit. They ascends above like this. The first one, this one, is supratrochlear. Second one is supraorbital. Another one is coming from there. The third one, that is the superficial temporal artery. Fourth, that is the posterior auricular, and fifth, the occipital artery. These 3 arteries are the branches from the external carotid, and these 2 are branches of the ophthalmic artery from internal carotid. So here they anastomosing with each other. So extensive anastomosis is here in this and from the opposite side also. So the blood supply is huge here. And as the blood supply is huge, so even if the extensive area of the scalp is being damaged, say any machinery caught up that here can avulse the whole surgical layer of the scalp. If we repair this, that can easily be repaired or easily taken up without any slapping. Why? Due to that extensive blood supply. Due to that extensive blood supply, there may be a huge hemorrhage over here if there is any small injury. But one thing is that if we look that even that the blood vessels ascending above like this. So when there is a huge hemorrhage, we are unable to control that. What we can do, we can easily give a tie over there by any string or cloth tightly so that it can compress the artery against the bone. So 5 arteries: supratrochlear, supraorbital, which are coming from the internal carotid system. So from the internal carotid, and these 3, that superficial, temporal, posterior auricular, occipital artery, they are coming from the external carotid system. So these are the arteries. Now the veins. Veins are also 5 in number and same named, but their drainage is different than the artery. That's why I have drawn a different picture to describe that. See, the first vein here, that was the same according to the artery. So supratrochlear, it is coming like this, and here it is the supraorbital. These 2 arteries, they unite at the medial angle of the eye, and now it is known as the angular artery. And that artery then descends downwards as, sorry, it is the angular vein, and that angular vein descends downwards now as facial vein, like this. Here, what will be the vein? The same name according to the artery, that is the superficial temporal vein. It descends downwards in front of the ear. Here lies the parotid gland. So here lies the parotid gland. Suppose here lies the parotid gland. So it enters within the substance of the parotid gland. Here it receives a branch from the maxillary artery, or it receives the maxillary vein. Sorry, it receives the maxillary vein. Thereby it is known as the retromandibular vein. This retromandibular vein will again divide into anterior and posterior. So superficial temporal vein, maxillary vein united to form that retromandibular vein. That retromandibular vein will divide anterior and posterior division. The anterior one will unite with that facial vein and forming that common facial vein, and that common facial vein will drain into the internal jugular vein. So this is the internal jugular vein. Now what are the 4th artery? Posterior auricular vein. 4th vein is the posterior auricular vein. it is coming downwards and it will unite with the posterior division of the retromandibular vein. Then it is known as the external jugular vein, and that external jugular vein will drain into the subclavian vein. Another vein is the occipital vein. It drain into the occipital venous plexus, or sometime it can drain into the posterior auricular vein. So again, I can name the vein, that is the supratrochlear, supraorbital. Here it is the angular vein. Then this vein coming downwards, here it receives venous drainage from alley of nose, upper lip, lower lip, and it is known as now as the facial vein. Facial vein. Facial vein, when it unite with that anterior division of the retromandibular vein, then it is known as the common facial vein. It drains into the internal jugular vein. It is the superficial temporal vein. It is the maxillary. It will unite with that to form the retromandibular. It is the retromandibular vein. This one. Posterior division of that retromandibular vein will unite with the, that is the posterior auricular vein to form the external jugular vein, and this is occipital one. So these are the veins of the scalp. Now regarding the lymphatic drainage, from the anterior part of the scalp, except the lower part of the forehead, it drains, say from this zone, they drain into the pre-auricular group of lymph node. From the posterior part, they drain into the post-auricular or occipital group of lymph node. So pre-auricular, post-auricular and occipital. That is the lymphatic drainage of the scalp. Now regarding the nerve supply, I have already described that when discussing the third layer, that the frontal belly and occipital belly, they are supplied by branches from the facial nerve, which is a motor nerve. Here in the scalp, we'll find that there are 5 nerves in front of the ear, 5 nerves behind the ear on both sides. Among these 5, 4 are sensory, 5. Among these 5, 4 sensory, 1 motor. Here also 4 sensory, 1 motor. Let me discuss one by one. The names are very similar to that artery and vein here. So as because they are coming from the orbit, they ascend above. So one is this one, that is same, that supratrochlear, and another one is supraorbital. See, it is coming that much, and it is larger than this supratrochlear nerve, and it gives 2 branches, one medial, one lateral. Medial one is basically, it pierces the frontalis muscle and supply here, and the lateral branch extends further. It pierces the Aponeurotic layer and supply this part. So see that these things, that means the nerves, arteries which are coming from the orbit, they are coming from deeper layer, so they travel a few area in the fourth layer. Then they pierce the third one and reach the second layer. So the loose areolar fourth layer contain these things only in this front part, other than the emissary veins. So supratrochlear and supraorbital. These two are the sensory nerve. They are coming from the orbit. They are branches of the frontal nerve from ophthalmic division of trigeminal nerve. Third thing, zygomatico-temporal, also sensory. It is a branch of the zygomatic nerve from that maxillary division of the trigeminal nerve. That is the third. Another sensory is this one, that is the auriculotemporal. It is a branch of the mandibular division of the trigeminal nerve. So these two from that ophthalmic division of the trigeminal, this one from the maxillary division of the trigeminal, this one from the mandibular division of the trigeminal. And in here another nerve, this one, it is the temporal branch of facial. This is that motor, and it will supply the frontal belly of that occipito frontalis. So see, there is 1, 2, 3, 4, 5 nerve in front of the ear. And among these, 1 is motor and 4 is sensory. Now, the nerves which are behind the ear, they are mainly coming from the cervical region. Other than this, the motor. The motor here is again a branch of that facial nerve, and that is that posterior auricular nerve. The sensories, the first one is the great auricular, ear auricle, great auricular. It carries the fiber from the fiber of the ventral division of the second and third cervical nerve. Then there is lesser occipital. It carries the fiber ventral division of the C2 cervical nerve. Then there is the greater occipital. It contains the fiber of the dorsal branch of second cervical. Another is the third occipital, carries the dorsal fiber of third cervical nerve. See, here is also 5. 1, 2, 3, 4, 5. These greenish at the sensory nerve, and this is the motor nerve. So, see, 5 nerve in front, 5 behind. Then we have seen there was 1, 2, 3, 4, 5 veins. We have seen that 1, 2, 3, 4, 5 arteries, and even earlier we have seen that there are 1, 2, 3, 4, 5 layers. So 5 layer, 5 layer, 5 artery, 5 vein, 5 nerve in front of ear and 5 nerve behind the ear, and these also are 5. So you can remember by this way that as a rule of 5. So we have discussed up to the veins, up to the nerves. Now comes to clinical correlations. We have already seen that there are few clinical application of that scalp. The first, we have described that surgical layers. That upper 3 layers, collectively 3 upper layer, collectively known as surgical layer, because we can separate them and they move as a whole, and the surgeon usually take those layers as a flap for different surgeries. Second applied, the important thing we have already described here regarding describing the fourth layer, the danger area of scalp, already described. Due to that, through the emissary vein, the infection can enter into the intracranial venous sinuses. That's why this fourth layer is known as the danger area of the scalp. Third, we have described that if there is any transverse injury at that extracranial aponeurosis, that can give rise to that gap over here. And also we have described here that black eye, why there is blackish around the eye when there is injury in the scalp, because the blood easily travel through this loose areolar tissue layer, as because there is no bony attachment of the third layer, so it can easily gravitate over here, and that gives rise to the black eye. We have also discussed that safety valve of this when there is an injury to over here, that already described those things. And now there is another thing we can describe here, is that two important things, caput succedaneum and cephal hematoma. These things usually we encounter after the birth of a baby, that we can see a swelling over the scalp, and that swelling, the commonest one is that caput succedaneum. It occurs due to interference in the venous drainage of the scalp. Suppose a head is coming down like this, and the birth spaces compressing over there, preventing the venous drainage. As a result, this part of the scalp, mainly it is the second layer of the scalp, become edematous. And if we draw this, suppose this is the skull bone, and here is the covering of the skull bone. So this one is the pericranium, fifth layer, loose areolar tissue layer. Then there is the third layer, and here it is the second layer, and here that swelling is in the second layer, and here lies the first layer. These are the hairs. See, this swelling is not following this suture line, because it is in the superficial layer than this. Whereas in case of cephal hematoma, here actually that blood accumulate in this layer. Here it is normal. It can happen maybe due to breakage of this vein, this skull bone, to give rise to accumulation of blood over here. Over there is that fourth layer, then there is the third layer, then there is second layer, and the skin. But this thing will follow these suture lines. So that is the difference between a caput succedaneum and cephalhematoma. Caput succedaneum will not follow that suture line. It is present in the second layer, in the superficial layer. Whereas cephalhematoma, it is present below the fifth layer, in between the fifth layer and the skull bone. And that I've already described that the pericranium is attached loosely over the bone except at the sutural line. That's why this accumulated blood can't exceed that boundary. This type of thing is usually occur on the parietal bone, and this thing usually occur on the occipital bone, because usually the occipital bone is coming like this in the presenting part of the head at the birth. So these are the things, these are the applied thing. So if we summarize, first extent I have described, then the layers, you can remember those things. 5 layers are there. You can remember the rule of 5, layer 5, then artery 5, 5 veins, and 5 nerve in front of the ear, 5 nerve behind the ear, and few clinical correlations. Thank you.